This is a very important issue. Um, Everett C. Koop, who was our Surgeon General of the United States a long time ago, who came up with the recommendation that smoking is bad for health and causes cancer, which led to people stopping smoking, famously said, medications don't work if you don't use them. And you could argue the same with CPAP therapy for sleep apnea. If you don't use CPAP, it's not going to work for you. It could be sitting in a shelf. Dr. Satyapala and I work across the pond in the UK and in the US, and we both work on promoting treatment adherence for individuals with obstructive sleep apnea. CPAP is the most common treatment currently in both countries. In the US, 93% of patients who develop or being diagnosed with obstructive sleep apnea are being treated with CPAP. 6% with dental device, and about 1% or less with the hypoglossal nerve stimulation device. And there's an emerging group of people who are getting GLP-1 drugs. But CPAP, therefore, is the mainstay of treatment. And what we explored is the common issues and the barriers and recent findings of how we can promote the adherence, either by doing motivational enhancement therapy or by doing peer-to-peer interaction where patients with sleep apnea educate other patients with sleep apnea to use the CPAP more regularly so that they can derive the benefit that they have personally seen there. And that is our purpose of writing that commentary, because those findings need to be implemented in the real world. A lot of research is discovered, written in journals, sits in libraries or in electronic libraries, gathering dust or silicon, and is not used to benefit patients in the clinic and in the bedside. So our recommendation was, this is an issue. We need to do a better job. These are some of the recent findings, and this is the ongoing work. We need to find a different and better way of bringing those discoveries to the patients in the clinic and at the bedside. And that was the reason for our commentary.